All right, last part of the chapter is the lymphatic system and disorders and pathophysiology of the lymphatic system. So I'll do a brief review of the lymphatic system. But if you want a more in-depth review, there is an optional lecture in Canvas that you can look at. So you should be able to explain pathophysiology of lymphatic system disorders, differentiate between primary and secondary lymphedema, identify and describe 7 stages of lymphedema progression. We're just going to mostly talk about the first 4 stages because that's what you usually see in the clinic, um, and briefly mention the other 3. We're going to look at lymphoma. So the 2 main lymphatic disorders that we're talking about are lymphedema and lymphoma. So with lymphoma, there are 2 different types, Hodgkin and non-Hodgkin, and we'll see what the difference is. And we'll talk a little bit about the role of physical therapy in lymphedema management and the clinical signs and symptoms of lymphatic disorders. But next quarter, when we're talking about compression for edema management, we will talk more about the physical therapy for lymphedema treatment. And we will have in one of our labs, we'll have a lymphedema therapist come and teach us some great techniques that you can take right into the clinic. It'd be awesome. So the lymphatic system, the circulatory system is circulating blood and all those cells and lots of different things going on. The lymphatic system, and so the circulatory system is one way, it's goes from the heart to the arteries to the capillaries to the veins, back to the heart to the arteries to the capillaries to the veins. So it's a closed system. The lymphatic system, it's taken up in the extremities and it's returned to the venous circulatory system. So it's a fluid management system. The key functions of the lymphatic system are fluid balance, so removing excess interstitial fluid and waste products. The lymphatic system is also a big player in the immune system. So that's where lymphocytes are stored and transported. So our B memory cells and our T memory cells that are just waiting there to be activated again, they're waiting in the lymph nodes. They're hanging out. So the lymph nodes are like little lymphocyte social clubs, and they're hanging out, looking for pathogens and waiting there. So the lymphatic system has an essential role in the body's defense systems and is very intimately connected with the immune system. So when the lymphatic system is damaged, lymph can accumulate in tissues, leading to lymphedema. And lymph is a protein-rich fluid that is more viscous than typical edema fluid. So the regular edema that you get with inflammation, lymphedema is different because it has to do with dysfunction of the lymphatic system. So the lymphatic system includes lymphatic vessels, lymphoid tissue, lymphatic nodules, tonsils, lymph nodes. The spleen is part of the lymphatic system. The thymus gland, which is where the T lymphocytes go to mature. So all the lymphocytes are created in the bone marrow, and that's also considered part of the lymphatic system. The B lymphocytes mature in the bone marrow. That's where the B comes from. And the T lymphocytes mature in the thymus gland. That's where the T comes from. So the lymphatic system is a big part of the immune system. It's a transport and storage system for all of those lovely lymphocytes. So lymphatic vessels originate in the capillary beds, with those capillary beds in the tissues, and they're in contact with the blood capillaries. The lymph is collected by lymphatic trunks, and lymphatic trunks empty into lymphatic ducts, and ducts empty into the subclavian veins, and it goes back to the circulatory system. So it's a big fluid return system. One analogy that I heard that I think is great is the lymph system is like a storm sewer. It is returning water back to the water recycling plant. So it's nice. And when you have lymphedema, when you have blockage or dysfunction of the lymphatic system, it's like the storm sewer being drained and water fills up the street because it doesn't have any place to go. So lymph itself is a clear, watery, isotonic fluid. It circulates in lymphatic vessels. It resembles blood plasma, but it has a lower protein content and it doesn't have erythrocytes, and it doesn't have platelets. There are lymphocytes, but no leukocytes in general. Sometimes leukocytes hang out in the lymph nodes just to be ready. Um, so they might be in there. The lymph, as it's circulated through the lymphatic system, is returned to the cardiovascular system to become part of the blood, basically. So, lymphedema is an accumulation of lymphatic fluid in the trunk or extremities due to lymphatic system damage. So, that's the main difference between edema and lymphedema is the accumulation because there is a problem with the lymphatic system. The lymph fluid is protein rich. Unlike other types of edema, you don't have that protein rich fluid, and that's going to affect the osmotic pressure of fluid return. So lymph is a little more viscous. It's thicker than serous fluid from typical injuries. And it can advance to what they call a woody feel, which is kind of interesting. It has a almost like a texture to it. The lymphedema is a stageable condition, and there are 7 distinct stages. The first 4 stages are generally the ones that you see. 5, 6, and 7 are pretty unusual. So primary lymphedema is congenital. It's present from birth. So you have developmental abnormalities of the lymphatic system, and it may appear at birth or puberty or later in life. So you might have an insufficient lymphatic system and it doesn't show up until later. That's that growth into deficit thing. So secondary lymphedema is acquired due to external factors. The most common cause of secondary lymphedema is cancer treatment with lymph node dissection. So people have tumors removed and they dissect the lymph node to either check if the cancer is metastasizing or remove lymph nodes if the cancer did metastasize. So if lymph nodes are missing, now we have the lymph system damage, and the lymph isn't going to drain the same. So it's usually secondary lymphedema is usually unilateral on the side where the lymph nodes were dissected. Other causes can be infection, trauma, radiation therapy. The infection cause is called filariasis. It's the most common cause of lymphedema worldwide. It's also sometimes called elephantiasis. And once you treat the infection, the lymphedema goes away. With radiation therapy, it's because the lymph vessels were damaged by the radiation, or trauma, same thing. So secondary to cancer treatment is the largest cause of lymphedema in the US, but there are other causes, and filariasis is the leading cause of lymphedema worldwide. So the early stages are 0 to 2. 0 is subclinical, so you have lymphatic vessel damage, but it's not apparent, and it still has enough transport capacity that you don't have any visible lymphedema present. So that's probably someone who has primary lymphedema and it hasn't started to manifest itself yet. Stage 1 is considered mild, and that's where swelling increases during the day and disappears overnight with elevation of the legs. So the pitting edema, it means it indents when it's pressed and it stays indented for a little bit of time. And when you wake up after lying down all night, it looks normal. Stage 2 is moderate. The swelling is not reversible overnight. It's non-pitting. So with pitting edema, you press in and it leaves a little pit. With non-pitting, you press in and it bounces back without indenting. The tissue is of spongy consistency, and fibrosis begins. You get the start of tissue hardening in the area. So in severe, it's irreversible swelling and the limbs become increasingly large, and you get hard fibrotic tissue that's unresponsive to mechanical stresses. And some patients consider debulking surgery at this stage, and there's some research to the different results in the research. 4 is considered very severe, noticeably large limb size and circumference. The skin changes, you get lumps, bumps, and protrusions, which are sometimes called knobs. And there's a significant cosmetic impact. Debulking surgery, again, the risks might outweigh the benefits, and it could make the lymphedema worse by causing additional lymphatic damage. Usually, comprehensive decompression um, therapy, decongestion therapy is the conservative treatment, and that's what we do in physical therapy. So when you look at these stages here, one of the things that you notice is only one side is affected, and that's really common. It's much more uncommon to have both sides be affected with secondary lymphedema. With primary lymphedema, you might have both sides affected. So the end stages that you rarely see, stage 5, deep skin folds, severe functional impairment, stage 6, clusters of small knobs, mossy-like appearance on the limb, and mobility is increasingly difficult. Stage 7, the patient is unable to perform daily activities, becomes handicapped. It requires assistance from family and the healthcare system, and it has a significant impact on the quality of life. If you cannot cure lymphedema, but you can manage it. And if you manage it, you don't get to these stages. You can stay in the stage 2 and 3. So that's more manageable. So just that's a good thing to think about. So clinical presentations, you get that increased limb girth, measurable circumference changes. One of the assessment techniques that we do is measure throughout the limb. A feeling of heaviness, and you have all that extra fluid. Of course, it's heavy. The patient will report that subjectively. Postural changes because they're compensatory patterns. Functional impairments, the psychosocial impact is huge. There's social and emotional isolation is common due to visible limb changes and public awareness of the condition. The problem is some people just think, oh, well, I'm just getting fat, unless it's after cancer treatment, and then they usually have some education on it. But some people don't realize that it's a pathological condition. They just think, oh, well, I gained weight in my legs. And that doesn't normally happen. So there is a huge risk of skin breakdown. So meticulous skincare is essential. There is a greater susceptibility to infection because you have impaired immune response when you have lymph disorder, and mobility changes, especially with lower extremity involvement. The one thing when you're doing lymphedema treatment on someone whose leg is really swollen, it is heavy. I mean, people's legs are heavy. That's what I always say in lab, right? When you add a lot of fluid, they're even heavier. And imagine how difficult it is to walk around with that. It's extremely difficult. So physical therapy, complete decongestive therapy is really important. So manual lymph drainage, and we'll learn that in lab next quarter. It's a specialized low pressure massage technique. It feels good and most people love it. The other thing is it's very effective, and you can use it on patients with normal lymphatic systems, and they respond really well to that post-surgically. Compression therapy, which is bandaging and compression garments, exercise, and we will talk about all these things in lab next quarter. And sequential pneumatic pumps, compression pumps can be helpful for mechanical lymphatic drainage. The bandaging is done with low stretch bandaging. High stretch, like ACE bandages, are less effective. The low stretch bandage puts more equal pressure and gets you the fluid movement that you want. Manual lymphatic drainage technique is a low pressure massage to open the lymphatic vessels and move fluid, and it's very effective. Compression garments are they're custom measured elasticized sleeves and stockings for easier application. So normally you'll get someone in, you'll do manual lymphatic drainage and bandaging till you get them down to the size where they can get into a compression garment, and then they use the compression garment for day-to-day management. And then usually they might come back if they, for some reason, fell off using their compression garment and their girth has expanded and they want to get back in the compression garment. So we can be really helpful for people in managing lymphedema so they don't get to the end stages. So there's no cure, but it is manageable with comprehensive physical therapy. So the interesting thing is the different parts of complete decongestive therapy, manual lymphatic drainage, bandaging, and serial compression, and mechanical compression can be done by different people. So massage therapists can do manual lymphatic drainage. Some nurses do compression wrapping. Some of the pneumatic machine vendors do actually do the treatment with the pneumatic lymphatic drainage, but only physical therapists and physical therapist assistants do the complete package, along with exercise and breathing techniques and management techniques. So that is really an advantage coming to physical therapy, and it doesn't have the risks of surgery. So for some people, lymphatic rerouting to redirect lymphatic flow or lymph node transplantation can be helpful. There are sometimes the risks outweigh the benefits, though. So physical therapy provides all the conservative management interventions for lymphedema and is the primary treatment approach for most patients. And you'll find out the therapist who is coming to talk to us in the fall is a physical therapist assistant, and she loves doing it because she sees how much she really helps people manage their lymphedema. And um, the fabulous techniques that we will learn in lab you can also use with your patients with normal lymph systems and have regular edema, and it's very effective. So great massage techniques that we will learn next quarter. So lymphoma is the other disorder that we're going to talk about, and it's cancer of the lymphatic system. So it involves hyperplastic production of abnormal lymphocytes affecting all lymphatic system organs. So there are two main categories, Hodgkin and non-Hodgkin. Um, the diagnosis happens through lymph node biopsy, fluid biopsy, and blood tests. That's how they tell that you have lymphoma. So when they do the lymph node biopsy, one of the things they're looking for is these large polynuclear lymphatic cells that are found only in Hodgkin lymphoma. They're called Reed-Sternberg cells. Remember that name, it'll probably be on the test. Reed-Sternberg cells are identified through microscopic examination of lymph node biopsy fluid. So the arrow is pointing to that Reed-Sternberg cell. You can see it's huge compared to the other lymphocytes in there, and it has multiple nuclei. So Hodgkin lymphoma is more common in males. There is what they call a bimodal distribution where you get a clump of people in the younger years, so 15 to 35, that tends to have a better prognosis, and the second peak over 55 years. So lots of risk factors. Exposure to Epstein-Barr virus or HIV or HTLV, family history, radiation exposure, all of those can predispose you to lymphoma. Hodgkin lymphoma spreads in an orderly fashion from one area throughout the body with symptoms appearing as organs become involved. So it usually starts with one lymph node, one area, and then spreads from there. So that's one, and it's organized, organized and orderly. It doesn't show up like here and then way over here. It goes in an orderly fashion. Non-Hodgkin lymphoma doesn't. It is random and a non-contiguous spread. So with non-Hodgkin, no Reed-Sternberg cells, mainly people who are over 60, and it's that random non-contiguous spread. A lot of times people with non-Hodgkin will have multiple enlarged lymph nodes, and it's an unpredictable spread. The prognosis for Hodgkin lymphoma is about 85% 5-year survival rate, which is pretty good. And non-Hodgkin, it varies by subtype. So the cell types that are characteristic of Hodgkin lymphoma are the Reed-Sternberg cells, and in non-Hodgkin lymphoma, it's damaged B lymphocytes or T lymphocytes. So you don't have those Reed-Sternberg cells. So for lymphedema management, key clinical points, physical therapy is the primary treatment approach for lymphedema management. And early interventions in the early stages are most effective. That goes for just about everything, right? Early intervention gets you better results. A comprehensive approach using manual lymph drainage, compression, exercise, and education gets you the best results. There's no cure, but you can manage and prevent the progression of the disease. With lymphedema, it's a progressive condition and it requires ongoing management. So the patient has to really be motivated to continue with the ongoing management. There is infection risk, so meticulous skin care is essential. You need to address the patient's emotional needs. With lymphoma, they need to be referred for immediate medical evaluation if it's suspected because they need to go through chemotherapy. Chemotherapy is the main treatment for lymphoma. And next quarter, we will talk more about oncology and cancer treatment in general and PT's role in that. But for PTAs, we implement lymphedema plans under the PT supervision. We recognize signs of symptom and appropriate referral patterns for lymphoma and lymphedema. So those are our essential critical skills for these disorders of the lymphatic system. And again, if you want a more comprehensive review of the lymphatic function, there's an optional video in the module, as well as a more comprehensive view of the blood system function.